Good afternoon. I'd like to thank the Society for AYA Oncology for asking me to introduce this next section of talks. The topic that I was asked to discuss is the microscope still relevant? The first 5 talks were enlightening, and I think they were a great setup for what we're about to discuss, because they actually talk about where the future is going and where the study of ALL is going and what we're going to gain from that. And the next few talks will be more about the day-to-day clinical practice that we see in pathology and pediatric oncology and in treating young adolescents and young adults. So my disclosures: I have no relevant financial or non-financial relationships to disclose. The objectives that I'd like to go through today, I'd like to give a historical perspective on leukemia, the tests available to diagnose and classify ALL, a look at the WHO classification of ALL comparing 2001 with 2008, some case reviews, and then to summarize. CML is really a good place to start in looking at the historical perspective. The BCR ABL positive, Philadelphia chromosome positive CML. It was the first leukemia described, first malignancy found to be associated with a chromosomal abnormality, the first disease to be found to be associated with a genetic translocation. And it was the first disease for which a drug was designed to counteract a molecular abnormality. So targeted therapy all started with CML, and it's really an interesting history when you think about where we're going now. The diagnosis of CML requires an evaluation of blood, bone marrow, and cytogenetics. The most important is the identification of the Philadelphia chromosome. This was a blood smear on a patient that was admitted from the ER with a WBC of greater than 700,000. Looking at a higher power view, we can see the various stages of maturation. The PCR studies were done, came back within 2 hours. The diagnosis was made. Bone marrow biopsy was not necessary. This patient was diagnosed with CML. So the tests that we have available for diagnosis and classification of ALL include CBC and peripheral smear. You just saw an example of that. Bone marrow aspiration and biopsy, flow cytometry, immunohistochemistry, cytogenetics, FISH studies, and PCR. This is the WHO classification for ALL, and this is the current 2008 classification for ALL. If you notice, there are 7 recurrent genetic abnormalities, as well as the B lymphoblastic leukemia, lymphoma not otherwise specified, and the T lymphoblastic leukemia, lymphoma, also NOS. In the 2001 classification, the recurrent genetic abnormalities were not in the classification. They were known genetic abnormalities, but they weren't in the classification. I think that the changes are going to be even faster as we move forward with the recurrent genetic abnormalities as we move forward with next generation sequencing and various genomic studies. These are the recurring chromosomal alterations that we now know exist. I think you've seen a slide very similar to this earlier today. Approximately 75% of childhood ALL cases harbor a recurring chromosomal alteration detectable by karyotyping, FISH, or other molecular techniques. I expect that within the next few years that is also going to increase at a faster rate. This is the first case I'd like to discuss. This was an 11-month-old male that entered with a high white count, WBC, of 539,000, anemia, and thrombocytopenia platelets were 22,000. The smear was obvious blasts, large atypical nuclei, prominent nucleoli. Differential showed on the peripheral smear 67% blasts. Flow cytometry shows a blast gate, fairly tight. This case was, these cells were positive for CD34, negative for CD10, B cells 19 positive, 22 positive, and TDT was positive. This, without going any further, is B lymphoblastic leukemia. What's interesting, though, is the CD10 negativity. With CD10 negativity, infant, high white count, FISH studies for MLL were positive. This was a B lymphoblastic leukemia with an MLL rearrangement. So basically the point I'm trying to make here is that Microscope was initially used to see that there were blasts, but beyond that the diagnosis was flow cytometry and FISH. Second case, this is a 19-month-old female, low white count, anemia and thrombocytopenia, and the blasts 22%. In a case like this, as a pathologist, you know it's going to be a difficult case. 22% blasts. It's going to be difficult to make a call of acute leukemia. This is the flow on the bone marrow aspirate. We see that this is CD10 positive, CD34 positive. They're B cells, CD19 positive, and what's interesting is this prep right here. This flow diagram shows that there is progressive expression of CD20. This would fit with the hematogone. So I would be very hesitant to call this acute leukemia based on what I have at this point. TDT was positive. Hematogones can be positive for TDT. Looking at the bone marrow, I don't know how well you see that, but there are basically sheets of blasts with some scattered histiocytes. The immunohistochemistry is quite informative. There's strongly positive for CD19. The TDT is positive, and there are many more cells than I would have expected with the flow results. This case I did gene rearrangement studies. That was positive, and then about a week later, it came back with a cytogenetic abnormality, 920 translocation. So with the gene rearrangements, I was able to make the diagnosis, but then the cytogenetics came back and actually just added more information. This is not a recurring cytogenetic abnormality. So it's B lymphoblastic leukemia, NOS. Third case, this is a 15-year-old female with a mediastinal mass and an enlarging neck node. We can see here that there's a partial involvement of this neck node. And malignant cells and scattered tingible body macrophages. Has a starry sky pattern, if you will. Higher power, we can see that these are blasts. Immunohistochemistry, TDT positive, CD3 positive, CD5 positive. This is a T lymphoblastic lymphoma. The point I wanted to make here was that if the neck node wasn't there and all we had was a mediastinal mass, the first tissue that we would have probably seen would have been a core biopsy of the mediastinum, and the diagnosis could have been made with a core biopsy. So the microscope could have actually made this diagnosis without flow as T lymphoblastic lymphoma. So as far as the question, is the microscope still relevant for the diagnosis of ALL? Of course, it's still relevant. Some cases can be diagnosed by flow and molecular tests alone, but the microscopic evaluation can actually eliminate certain tests, and when we're looking at test utilization and to decrease costs, that can be very important nowadays. The light microscopy and the IHC always add additional information and confirm the diagnosis. Eventually, I say nearly all leukemias will fit into a molecular profile, which hopefully will direct treatment for targeted therapy. And I think that one of the reasons that we also need to keep the microscope in mind is that there's always a differential diagnosis. Small round blue cell tumors. And this is my full disclosure. That's my microscope. So I am a little bit biased, but there's another reason I wanted to show this slide, and that is that I look at this and I think, well, maybe the next generation, and hopefully the next generation of pathologists, instead of having a microscope in front of them, will have a high-definition monitor. And to think about that, it would be great as far as cataloging cases, annotating cases, and using those cases and sharing those cases globally for consults and just for interest's sake. So I think that as we stand now, the microscope is important and will probably remain important, but things are going to change, and I just think that probably that next generation would do well to have digitized slides without having to carry around flats and worry about storage. That's it. Thank you very much.